Okay, so I will try to go straight to the point before we get hypoglycemia. So I'm coming from Austria. Then, yeah, I'm from Mexico, but I'm living now in Austria. And I find pretty much a relationship with stem cell research because Mexico City is actually like stem cell research. It's beautiful. Everybody wants to go there, but everybody is afraid of there. So talking about clinicians, it's pretty much the same. And Vienna is an appropriate environment to work about this. And it's nothing to do, but I'm so proud. This is my boy. He's 5 months old. Okay, taking into the point. Okay, so the situation about, I'm going to talk about this traumatic brain injury. As you may know, this is a high prevalent disease, and there's nothing that now there's no treatment that we can say, okay, this improved the outcome of the patients. About 5,000 people die every year in US, and furthermore than dying, the disability that this causes. So until now, as I said, no clear decrease in TBI-related mortality. The second important disease is spinal cord injury that is also highly prevalent. It causes it is also in young people, and there's nothing to do about it. And this is not exactly a traumatic disease itself, but it runs in the same line because of the matter that I want to talk about, that is stroke. That it's also the leading cause of disability, of major disability. Just to make an idea, while we are speaking here, before we go to lunch, there's going to be 5 persons that are going to die in consequence of stroke or major disability. So these are theoretically preventable diseases, but we are not getting there yet. So we have to look for another option. And as I say, these 3 treatments, the treatments approved for these diseases are not getting to the point. So in the treatment, you can do rehabilitation, a lot of physical, electronical, all kind of rehabilitations, and the people still have the disability. So no treatment with efficacy, not even in experimentation. So that's where we can apply the cells. So I have to say, I'm clinician, so we are skipping a lot of the basic science that you know better than I. So why we use autologous bone marrow stem cells? Because the secrete factors, and also because of the neuroprotection and the inflammatory suppression and the neural repair. But mainly, we want to highlight, as previous conference, that we are attending to this because of the neuroacute protection. That has to do with the secrete factors and to do with potentialized the normal functioning of the neural cells. So as we know, the systems are made to, when it's trauma, when it's an injury to the system, the cells are trying to get the best, to get lowered inflammation, to get healing as soon as possible. The thing is that it's not enough, our system, to do that, and then goes the consequence. Okay. So another thing that happens here is neurovascularization, transdifferentiation, further in the therapies, neuroplasticity, etc. The advantages of autologous, that there's no ethical or immune concerns, and is relatively easy process to harvesting these cells. So there's have been published papers about this with few patients, but basically in 2005 with brain injury, with improvement of the outcome. There was no comparing group. It was single trial with few patients, but it was made before 48 hours, after 48 hours of the injury. Then one subacute, after 1 month of the injury. And both of those show some a better outcome. Then we have in spinal cord injury also in acute. There's these 2 papers already published in acute patients that they are improving the age score, and they are improving also in the motor function by different scales. Then someone made it in 3 groups: acute, subacute, and chronic. And as we can see, in the chronic patients, there was no improvement compared to the acute and subacute. And the most improvement was in acute patients. That was 2 weeks after 2 weeks in the range of 2 weeks of the injury. In a stroke, happens the same, and recently publications of the stroke and the influence of the inflammasomes that has to do with the injury and the post-acute injury that may be telling us that we are getting into the right way. So why acute? Why acute? This is what we want to do. This is acute protocol of patients. We have been treated. We have been treated chronic patients after years or after months of the injury. There's some improvement, but there's no the improvement that we want because several conditions. But basically, the method is very easy. All of us, I think we know. It's harvesting from bone marrow, about 200 cc's. It goes to a closed system that makes minimal cell manipulation. It's a simple separation by centrifugation method. It's important to say there's already one group that said about that this extraction, this aspiration in acute patients does not cause any hemodynamical disturbances. Then we can get about 8.5 million cells measured by the CD34. And then why we measured this, because there's already publications about the correlationship with clinical improvement and the number of CD34 positive. And then what we do is we take these cells, we take the buffy-cold, and then go back to the patient in about 25 minutes and to the cerebrospinal fluid. Recently, another publication about how the cerebrospinal fluid can influence in the transdifferentiation of stem cells into neurons. It's very important because, as you've seen, I didn't say that, but I've just seen these previous studies. They make intravenously, so they make almost the same process, but they inject it intravenously or intraarterially directly in the brain in the case of stroke. But maybe this can be a good idea to go also into cerebrospinal fluid. So lumbar puncture, it's a minimal invasive procedure. We have been doing that for a lot of decades, not me, but the people. And then it has not problem between the blood-brain barrier. When it's an acute injury to the brain, some studies have said that there's a disruption in the blood-brain barrier. Furthermore, if you inject, you overcome this part. But also maybe that these stem cells IV can help to reconstruct the blood-brain barrier. But we are still in that. So we have treated 61, I'm just talking about spinal cord injury. We have treated 61 patients with spinal cord injury. We followed them 6 months. The mean time since diagnosis was 72 months, so it was long after the injury. So that is a problem because the selection of the patient, even if it's acute, has to be very carefully because the patients with a big defect, it has no sense to treat them. Or the patients after several months they get syringomyelia, and there's no reason to treat them because such a big defect with such small number of cells, as you see, it's about 8 million. It's not a lot of cells. In chronic patients, there's not a lot of improvement, even though we saw that 62% improve muscular strength. Half of the patients improve sensibility and half of the patients improve spasticity. This has to do, it's correlated directly with the condition of the patients before, if it's complete or incomplete section, and if it's, and how many cc's are of the defect. No patient had any side effects, that this is good to say, except for some headaches because of the lumbar puncture. Okay, so this is what we have done and what we want to do, and this is the study that it's running, and I hopefully next year I can give results about this one. So it's safe, it's clinically safe team. It can be reproducible because the system, it's small amounts of the technique of aspiration. Yes, it has to do with the practitioner, but the process, it's a small induced with human error, in a way of speaking. There's effectiveness in chronic patients, but it's not satisfied. When you have spinal cord injury, maybe it doesn't matter if you feel a little bit more, or if you can move and twitch a little bit more leg. It matters if you maybe can walk. So we think we're ready for a randomized control trial, and as soon as we get the grant, we're doing it. Then what we want to do in this time, because we want also to fulfill all the requirements of basics, to put also imaging to track stem cells. So this is not available. There's two papers about that, but it's in animals model. But this could be the way to say, yes, these cells are there in the defect, and these cells are maybe doing their job. And we just think that to be successful man and science does not need to be complicated. Also, simple solutions for complicated problems, and then in clinical field, sometimes simple solutions make a good effect. And this is our team, and that's it.
Okay, very good. Questions here. So, 93% of your people had a general increase in health. 93% of the people who had this treatment had a general increase in health. Can you just tell me what you meant exactly by that?
Yeah, it was a questionnaire. It's subjective feeling about after the transplantation. That's why I didn't put too much attention into that. Even if it's very good, it's important for the people to feel better. It doesn't give us any results about if it's working or not, because it could be the placebo effect, could be that they just are doing better because of other consequences. But generally speaking, yes, 93% had these improvements, and it was a questionnaire.
Is it psychological, because they've received some treatment? Sorry.
Yeah, maybe the placebo effect about they are getting stem cells and this is super treatment, so I feel better.
So something I think you could help us with, if you don't mind going back a few slides to your summary. That one.
Yeah.
Some of people here are clinicians, others aren't. And so even though we understand that you're headed toward blinded, randomized studies, it would be helpful to get a sense of, for those numbers, what do you see in your practice when you haven't transplanted anyone? For the same kinds of, so for instance, you're saying that after the transplant for these 61 patients, 50% improved in spasticity. Okay. How many patients improve in spasticity?
Without.
Yeah.
Yeah, okay. Comparing, because we don't have a control group, we didn't do a control group, but if we compared,
historically,
we see historically groups,